So, hello to the audience. Hello, Ilya, all my colleagues. Wonderful to join this wonderful conference second time. I'm really be happy that for the invitation. And yes, I will try to give some informations about the same story I mentioned last year, but maybe with some different with some different remarks on it. So let me see if I can share. Well, so far I hope you can see the screen. So the talk is, if you are looking for longevity, don't die from cancer. And as you can see here, cancer is still one of the top killers. For example, here in Europe, where it brings 26% of all deaths in 2018. So this German Center for Personalized Prevention and Optimization is using a new approach for early detection of cancer, and this presentation wants to explain the setting up. The earlier a cancer is detected, the more treatment options there are, so more lives can be saved. The European Union has recognized the need of early detection, as you can see in the presented statement from 2022. Early detection of tumors significantly improves the survival rate. The 5-year survival rate increases dramatically if cancer is found in the early stages of tumor development. This can be postulated for all cancers. So cancer screening is highly recommended, and there are various ways to screen for cancer early out there, such as mammography or colonoscopies or various ELISA tests. However, none of these is suitable for universal cancer screening due to high price or limitation on single tumor entities or insufficient sensitivities or specificities. Approximately 300 different types and subtypes of cancer are known worldwide, which vary greatly in occurrence, frequency, and consequences. However, in Germany, there are only 5 types of cancer for which regular screening examinations are currently reimbursed by the health insurance funds. For example, breast cancer, which counts for 14.5% of new cancer cases annually, prostate cancer, 12.8%, and you see colon cancer, skin melanoma, and cervical cancer. These 5 types of cancer account for about 45% of the approximately 500,000 new cases of cancer in Germany each year. For the remaining 55%, there are currently no statutory measures for early detection. If you assume that all people would regularly take advantage of screening offers and that all examinations would work flawlessly, more than 250,000 new cases of cancer would remain undetected in this country every year due to a lack of symptoms and a lack of early detection methods. While the usual approach involves developing a specific screening test for each individual type of cancer, the question arose as to whether there were commonalities that could be used to identify cancer cells. This is where the findings on the metabolism of cancer cells came into play. If it were possible to identify the specific metabolic changes, it would be possible to distinguish between a sick person and a healthy person. This in turn would initiate more detailed diagnostics. Cancer screening is a crucial aspect of modern healthcare. To achieve effective early detection, we need a method that can ideally identify all types of tumors. This universal approach should not only detect various tumors, but also meet several other important criteria. Firstly, the method should demonstrate good sensitivity, meaning it should reliably detect as many tumors as possible. While high sensitivity is important, it's not the sole determining factor. Even a sensitivity of 50% would be a significant improvement over having no screening at all. This logic was applied, for example, when introducing prostate palpation as a standard screening procedure, despite its ability to detect only about 1/3 of tumors. Specificity is perhaps even more critical. This measure indicates how many false positive results are generated. In cancer screening, where the incidence of the disease is relatively low, it's crucial to minimize false positives. Too many false positives can lead to unnecessary stress and further testing for healthy individuals. The ideal screening method should also be able to distinguish between benign and malignant tumors. While detecting precancerous lesions is important, it carries the risk of overdiagnosis and overtreatment. This is less problematic for easily accessible areas like the skin or colon, but becomes more challenging for internal organs. Current imaging techniques such as CT, ultrasound, and MRI have limitations in differentiating between benign and malignant tumors. So biopsies can provide more definite answers, but they are not always possible or practical. And in some cases, monitoring tumor growth over time is necessary, which can be stressful for patients. In conclusion, the ideal universal cancer screening method should be highly sensitive and specific, able to distinguish between benign and malignant tumors, and practical for use across various organ systems. So what about changing the strategy? So this is when a multi-cancer filter test in combination with PET-CT was born. So the idea was a multi-cancer filter to allow the targeted use of imaging technologies. The criteria is to meet universal, sensitive, true early detection, specific, and affordable. If we are talking about cancers as malignant transformation of cells, how can we assess malignancy? We can look for growth rate, growth behavior, cell differentiation, invasive growth, and metastasis. In 1995, the gene encoding transketolase like 1 TKTL1, a unique derivative of the enzyme family of sugar metabolizing transketolases, was discovered by Johannes Koy at the German Cancer Research Center in Heidelberg as part of a genome analysis project initiated by later Nobel laureate Harald zur Hausen. Already in their first description of the gene, its transcripts, Koy and colleagues suggested that the protein may have altered enzymatic activities and may form a heterodimer with the normal transketolase TKT. In 2019, a Chinese study confirmed the presence of TKTL1 TKT heterodimer as well as the altered enzymatic activity caused by TKTL1. The altered enzymatic activity leads to a strong increase of ribose, as you see, and the essential building block for DNA. Thereby, TKTL1 enables and controls the DNA duplication and the cell cycle. The acetyl-CoA production of TKTL1 created a previous unknown metabolic link between pentose phosphate pathway and lipid synthesis. TKTL1 directly triggers stages 1 to 2 of malignant transformation by increased sugar metabolism. Prior to mitosis, the TKTL1-induced sugar metabolism does not only provide ribose as essential building block for DNA synthesis. By providing acetyl-CoA, it even enables the effective conversion of sugars to lipids or fatty acids for the construction of cell and organelle membranes. The exact processes were presented by Li in 2019 in the Journal of Nature Communications. The theory developed by Li shows, however, that TKTL1 is expressed first, followed by the transformation of a heterodimer from TKTL1 TKT, which significantly accumulates ribose 5-phosphate, thereby triggering the cell cycle. This push effect, TKTL1-induced increase of ribose 5-phosphate concentration, controls the synthesis of new DNA. TKTL1 expression directly or indirectly triggers all stages of the development of a tumor from a benign stage to an invasive malignant stage. Stages 1, the accelerated tumor growth, and 2, displacement of the healthy tissue, are triggered directly through TKTL1-induced increased sugar metabolism. Stages 3, 4, and 5 are triggered indirectly through the creation of an acidic pH in the tumor milieu by lactate excretion as a metabolic byproduct of TKTL1 metabolism. The expression of TKTL1 initiates diverse stages of malignancy progression. The entire process, starting from TKTL1 expression in individual areas of the tumor tissue to metastatic disease, is initially slow and hardly noticeable. With the enlargement and multiplication of TKTL1 expressing tumor areas, the process gains momentum, and it is progressive and there's no turning back. Finding a biomarker given evidence of cellular changes, I want to introduce the Pantom Detect test. Pantom Detect is a blood test by detection of enzymes, DNase X is APO10 and TKTL1, which occur both in elevated concentration in all cancer types. The test is based on EDIM technology for detection of special enzymes inside immune cells, macrophages. The importance of TKTL1 as a trigger of malignant transformation has been elaborated in recent studies. The expression of TKTL1 and DNase X as its companion biomarker for proliferation can be reliably measured in macrophages. This is indicated by results of studies that have investigated the technical functionality of the EDIM technology, but also by the results obtained in studies with tumor patients. Since TKTL1 formation is also upregulated in inflammatory processes, the EDIM technology using only the marker TKTL1 runs the risk of detecting not only the presence of malignant cells, but also the presence of inflammatory foci without a possibility of discrimination. This is because the EDIM technology does not allow differentiating between TKTL1 containing macrophages from inflammatory lesions and those from tumors. This risk could be significantly reduced by a co-identifying marker that is found in tumors but has no link to inflammatory processes. For this reason, it was decided to use a second intracellular marker and to evaluate it in the context of TKTL1. This is an epitope of deoxyribonuclease, DNase X, an endonuclease involved in programmed cell death. Overexpression of DNase X indicates inhibited apoptosis and appears to be an early event during the development of precancerous lesions. DNase X does not respond to inflammation. It's a universal marker for tumor activity in general, without differentiation between benign or malignant. The joint use of the markers TKTL1 and DNase X effectively reduces the detection of inflammatory processes and provides indication that the process of malignant transformation in tumor cells is active or has already been completed when very high TKTL1 levels are detected. Together with the advantages of the EDIM technology, this results in the best possible combination for a blood test for early cancer detection so far. For the processes how to do this, I will skip here because of time. But coming to the processes itself, repeating the simple blood test every year, it improves the chance of detecting cellular changes in time. In our clinical work, we can see that in very early stages, only APO10 is elevated. Then also TKTL1 is coming up. The algorithm of both parameters characterizes the turning point. And how do we combine these biomarkers with imaging procedures to close the gap? Now, Pantom detect can provide first indication of dangerous tumor growth, but cannot provide an indication of location of this growth. If patient anamnesis and further examination do not provide clues of tumor origin, modern imaging procedures such as MRI or PET-CT are needed to confirm and localize tumor suspicion. Coincidentally, FDG PET-CT makes use of the increased energy metabolism characterized by the requirements of more glucose in cancer cells to detect cancer. And as described earlier, TKTL1 is the responsible trigger for this elevated energy metabolism in form of the pull effect described by Lee. There's a direct rationale between increased concentration of TKTL1 and the accumulation of radiolabeled glucose in tumor cells, which can be visualized in PET-CT. This makes the combination of the marker TKTL1 and FDG PET-CT examinations ideal for cancer screening. The pretesting by an inexpensive and low-stress blood test enables the targeted use of FDG PET-CT for screening. The screening program is aiming at healthy people. They take a blood test once a year. Abnormal results, about 2 up to 3% of the examined subjects, are clarified with further diagnostics. Imaging procedures up to PET-CT are used. Patients diagnosed with cancer are then given specific treatment. In a study with more than 5,000 supposedly healthy subjects, imaging procedures were performed on 151 people following the positive Pantom detect result. In 124 of the 151 people, the imaging provided evidence of cancer or precancerous conditions, thus confirming the result of the Pantom detect test. This result indicate that the Pantom Detect blood test could be used as a screening tool and, in combination with PET-CT and MRI, enables the detection of malignant tumors and pre-malignant lesions at a stage where, in many cases, there's a good chance for a cure. If we do not have a specific test available for each entity of cancer, or if we have too risk screenings and techniques, or screening of the population will be too expensive adding all specific tests, one option could be to use this metabolic approach in a combination with imaging procedures to add information for early detection of cancer. To sum up, prevention and early detection of cancer is one step to longevity. Combination of immunological biopsy and imaging technologies can help for early cancer detection and maybe can improve survival rate and also keep life quality up. New partnerships between insurance companies, as we did in Germany, industry, political opinion leaders, and physicians can shift the actual paradigm from illness to healthiness. A pilot project within an entire health system would be desirable to prove the benefit for an entire society. So thank you for your attention, and if you have any questions, don't hesitate to contact me. We are looking for partners for investigations and all other situations. Thank you for your attention and have a great afternoon.
Thank you. Questions?
I have a question if this method can be used also for hematological tumors.
So far not.
Okay, did you test it?
Yeah, we have seen no very good correlation in this. So it's good for, let's say, tumors in organs. So far, more than 40 up to 45 different tumors could be investigated by this technology. It doesn't work very good on skin cancer and blood cancer so far.
And can it be used also for pediatric tumors? I'm asking this because sometimes in pediatric tumors, let's say osteosarcoma and Ewing sarcoma, there is a problem in diagnosis and confirmation, and there are invasive procedures in order to understand, can it be used like not for like for early detection or to validation that actually there is no metastasis of Ewing sarcoma?
Well, first of all, to mention, this test is in that situation only used for healthy people, not for already persons having any oncological problem. And because it's a very new approach, we focus on people between 35 and older. Probably because the technique should investigate in all ages, I would guess that it should work, but more research is necessary for that.
Thank you.
There are some researchers that claim that there are many small tumors in people that would not develop into the deadly ones, and wouldn't you, with this type of screening, have the effect of a lot of false positives, but really a lot of false positives, because the tumors do exist, but they would not develop into something. I mean, I read that someone that analyzed women that died in circulation accidents. They were about the age of 50, and half of them had breast cancer, small breast cancer tumors, half of them.
I don't think this, because it's a combination of two markers. APO10 is a marker for, let's say, a tumor, benign or malignant. But changes in TKTL1 is a marker for changing metabolic situation in the tissue and in the tumor itself. And that is let's say, there is a critical turning point when TKTL1 is getting higher and higher, where there is, let's say, it's a one-way situation. And that makes, I think, the test also very interesting, because you can differentiate between the beginning tumor and seeing, let's say, at the beginning, small amounts of APO10, maybe very, very small amounts of TKTL1. But there's a specific algorithm used to identify the turning point from, let's say, tumor to cancer.
Hey, is there any connection between this gene and cancer in a Neanderthalim? How do you say it in English?
Neanderthal.
Yes.
Yeah, there was a research done that this enzyme makes it possible to overcome the status of Neanderthal and going to the Homo sapiens. This is a different story, a long story, and probably Dr. Johannes Koy could explain it much better than me. But indeed, there is a link between. It's that enzyme which makes the change.
So it's mean they have less cancer?
No, I
Or we
wouldn't
don't
say
know?
that. It's a different metabolic situation, and it protects because it's not an pro-oxygenic pathway. It protects some tissues. And for example, in our retina, this lactatic pathway is more prominent and more necessary, because if we would have too much free radicals, we would destroy retinal function, and that makes the TCA-TL1 enzyme and pathway so interesting for the further development of Homo sapiens.
Okay. Thank you, Maria, for your, I would say, very promising presentation. And I wish you all the success in your future work. Thank you very much.
Thank you.
Thank you.